Hi everyone, Dr. DeFelice here, and today we're going to be talking about harm and etiology questions. So our objectives are that by the end of Module 3, you will be familiar with applying PICO format to harm and etiology clinical questions. We will be, again, evaluating the validity, assessing the results, and evaluating patient applicability of studies about harm. And we will look at some statistical tools for harm assessment. First, we have to think about, in a clinical context, what is harm? Well, harm is any adverse consequence of exposure to an intervention. This is important to us, particularly as clinicians, because we want to keep our patients as safe as possible. And here in this study called Medical Error, the third leading cause of death in the US, we see that in 2013, medical error was the third most common cause of death in the US, behind heart disease and cancer. We're also looking at etiology, and just as a reminder, etiology is the cause of a disease or a condition. So let's start off with our clinical scenario. We have a 32-year-old pregnant woman, G2P1, coming into the office. Her first child had an intolerance to cow's milk as an infant. He was switched to soy formula and then soy milk, which he subsequently tolerated well. Because of her first child's intolerance to cow's milk, the mother was planning to start feeding her next child soy formula at birth. However, she heard that feeding her baby soy formula could lead to the development of a peanut allergy. The woman wants to know if she should avoid feeding her newborn baby soy formula. She schedules another appointment for next week, and the attending physician asks you to do some research and report back. Remember, when we look at our hierarchy of evidence, that it's the experimental studies that we look to that have the least risk of bias and the most amount of validity if done right. However, some questions can't be answered by experimental studies because doing an experiment on people could cause them harm. So then we look to our observational studies. So remember, we talked about this. Why are there so many study designs? So we talked about experimental studies. They're great for providing evidence for best practices, but they're not always appropriate, ethical, or feasible. That is where the observational studies come in, right? So for evidence-based practice, we can use these types of studies to gauge patient-important outcomes such as harm and prognosis. So that is what we're going to be looking for in our PICO question. And just as a reminder, we have several observational study designs. We have our case study and our case series, our cross-sectional study, our case control study, and our cohort study. Most likely we will be looking for a case control study or a cohort study in this circumstance. So just as a reminder, our clinical scenario, she wants to know if she should not feed her baby soy formula because she does not want this baby to be at risk for developing a peanut allergy. So our PICO question, for our population, we have infants. For our intervention, it's exposure to soy formula. For our comparison, it's no exposure to soy formula. Our outcome that we're looking at is a peanut allergy, whether or not the child would develop a peanut allergy. And our type of clinical question that we are asking is a harm or etiology question. And for the answer, we will most likely find an observational study. So we are looking for a study that answers the question, among infants, is exposure to soy formula versus no exposure to soy formula associated with the development of a peanut allergy? Well, we do a search and we find this article from the New England Journal of Medicine. Factors associated with the development of peanut allergy in childhood. And very quickly, here is the abstract, which you should have already read, but I will give you a second to kind of refresh your memory here. And after we've found our article, it's time to assess validity, assess the results, and assess for applicability to our patient. So first, we're going to assess validity. But before we assess validity, we have to ask ourselves, what type of study is this? And recall the two most likely types of observational study designs that we will encounter to answer this question would be the case control study or the cohort study. So we know it's an observational study, but there are different types of observational studies. One of those types is the case control study. So just as a refresher, let's just go through what a case control study is. So a case control study compares exposure histories in people with a disease. So these would be your cases right here. People have the disease, and people without a disease, and those would be your controls, hence a case control study. You want to look back in time and see if the cases and the controls have different exposure histories. So you look back and you see how many were exposed, how many were not exposed. And then you compare that to the controls, how many were exposed and how many were not exposed. Case control studies can identify possible risk factors for a disease or an outcome. We also have cohort studies. That's another study that's observational, right? And these start with a single defined population, and we follow that population forward in time to determine if an exposure is associated with an outcome. So here we have our cohort, and we go forward and we see these people are exposed. Do they or do they not develop the disease? These people are not exposed. Do they or do they not develop the disease? We can also go back in time for a retrospective cohort study and determine that way, look at medical records and see if exposure is associated with an outcome. So, like I said before, in order to assess validity, we have to figure out what type of study this is. So let's look at the methods section. We can see that they say we first prospectively collected data on the whole cohort and then collected detailed information retrospectively by interviews from the parents of children with peanut reactions and of children from two groups of controls. So don't get misled by the whole cohort and prospectively, retrospectively, because this is a case control study. You see that we have a group of children with peanut reactions, so those are our cases, and a group of, or two groups of controls, okay? So our main question that we want to ask when we are assessing validity of a case control study is this top question right here. Did the cases and control group have the same risk or the same chance for being exposed in the past? To help us answer that question, we are going to ask the following two questions. First, we're going to ask, were the cases and controls similar with respect to the indication or circumstances that would lead to exposure? So in our study, the cases and controls appeared to be similar because they were all newborns who may or may not have been exposed to soy, but there were a few things to consider. So in the peanut allergy group, a family history of peanut allergy was more common, as was having an older sibling with a history of cow's milk intolerance. So this may have biased the likelihood that the child would be exposed to soy, but to avoid confounding, the investigators conducted an adjusted analysis. And this in the article is where we see the analysis of the detailed interview data, where it says of the 23 children with a positive peanut challenge test, 4% had a family history of peanut allergy. So that was a statistically significant result that they adjusted for. So the next question we need to ask is, were the circumstances and methods for determining exposure similar for cases and controls? And in our study, I would have to say that yes, the methods for determining exposure were similar for cases and controls. They were interviewed and the data were obtained with both the interviewers and the parents unaware of the study's objective that associated soy exposure and peanut allergy. Based on the validity criteria, would you rate our article a strong or a weak study? So after we have assessed validity, we will assess the results. And we have two main questions that we really want to ask. We want to ask, how strong is the association between exposure and outcome? And how precise was the estimate of risk? So to help us answer the first question of how strong is the association between exposure and outcome, we are going to ask, what is the risk ratio or odds ratio? This time we are given an odds ratio. We also want to ask, is there a dose-response relationship between exposure and outcome? So let's assess our results. So we have some odds ratios, and before they said that they did adjusted analysis to account for the family history. So we have our adjusted odds ratio, and we see an odds ratio of consumption of soy milk or soy formula, and developing a peanut allergy. And so our odds ratio for yes, consumption of soy milk or soy formula leads to a peanut allergy would be 2.61, okay? When we remember how we read our odds ratio, we look down here and we see if odds ratio is equal to 1, then odds of exposure were the same for cases and controls. If odds ratio is greater than 1, then the cases had greater odds of exposure than controls. And if odds ratio is less than 1, then cases had lesser odds of exposure than controls. So we see our odds ratio of 2.6, which means that yes, cases, those who had peanut allergy, had a greater odds of exposure to soy milk or soy formula than those who did not have a peanut allergy. We also had the question that we wanted to ask, is there a dose-response relationship between exposure and outcome? And here we see the researchers did not evaluate the possibility of a dose-response relationship for soy exposure and the development of peanut allergy. The next question we want to ask when assessing results is, how precise was the estimate of risk? And we are just going to see what is the confidence interval for the odds ratio. And we see our confidence interval is 95%, ranging from 1.3 to 5.2 of our odds ratio. So in that nice 95% confidence interval, we see the lower bound of our confidence interval is 1.3, and that still is above 1. So that's significant for the conclusion that the cases had greater odds of exposure than controls. We can say that with a 95% confidence interval. That means if we repeated this particular study 100 times, 95 times out of 100, we would find results within this range, which would still be significant. So next, after we have assessed the validity and assessed the results, we do have to assess for applicability. That is a hard word to say, to our patient. So these are our main questions right here. Were the study subjects similar to our patient? Was the follow-up sufficiently long? Is the exposure similar to what might occur in your patient? What is the magnitude of the risk? And are there any benefits known to be associated with the exposure? So in answering the first question, were the study subjects similar to the patients or our population? Is our patient so different from those included in the study that the results may not apply? So this is our patient. Remember, our patient is actually the infant once he or she reaches early childhood. So we look to the eligibility criteria of the study and we see, would our patient likely fulfill the eligibility criteria of the study? And we see yes. Something to consider though are the soy products considered in the study similar to the ones that the patient is considering using? The next thing we want to consider is, was the follow-up sufficiently long? Were study participants followed up long enough for important harmful effects to be detected? And so we can see that our subjects, they were recruited among women whose expected delivery date was between April 1991 and December 1992, and follow-up has continued since enrollment. So this study was published in 2003. So that gives us a good 11, 12 years to follow up on these patients that were fed soy formula for the to see if the risk of developing a peanut allergy from exposure to soy formula would develop. So in that case, I would think yes, that this was a sufficiently long follow-up. Next, you're going to ask, is the exposure similar to what might occur in your patient? Are there important differences in exposures, for example, dose, duration, etc., for your patients? So let's think about babies that drink certain amounts of soy formulas. They're not going to drink really drastically different amounts of soy formulas. So I would say that exposure would be similar among the study participants, as well as among our patient. What is the magnitude of the risk? So what level of baseline risk for the harm is amplified by the exposure studied? When we look at the magnitude of risk, we can see that the risk of developing a peanut allergy as a result of early exposure to soy, it's actually considered a small to moderate risk. However, we also have to think about the consequences of a child developing a peanut allergy. Peanut allergy can be a really serious health threat to a patient, and the ripple effects of childhood peanut allergy are felt by the family because of the required precautions, like always having an EpiPen, cost, and food restrictions. So we have to ask then, are there any benefits known to be associated with the exposure? What is the balance between benefits and harms for a patient like yours? So there is a balancing act between potential benefits and potential harms. The patient and the clinician often work through these benefits and harms, and we weigh the pros and the cons. So in this case, we have to ask the question, how high is the risk of developing a peanut allergy after early exposure to soy? And we said it was kind of like a low to moderate risk. Does the patient, or will the patient, have a need for soy formula? So remember, the sibling had an allergy to cow's milk formula, and that's why the sibling was switched to soy formula. So do we even know if the patient is going to have a reaction to cow's milk formula at this time? Do we wait and see? Or do we preemptively prescribe the soy formula at the risk of raising the likelihood, however small, that the child may develop a peanut allergy? So our patient, she wants to know, should she avoid feeding her newborn baby soy formula? We weigh the benefits and risks, and I'd like to know, what do you tell the attending physician regarding what your research and this article told you?